صباح الخير يا جماعة. احنا سعداء جدا ان احنا نبتدي النهارده new technology. Good morning everybody. I'm delighted here to start our workshop talking about a new technology regarding the use of microwave in ablation of varicose veins. It is a very recent technology. As you see, EMWA stands for endovenous microwave ablation. It is a new method for treating varicose veins. And try to imagine the first case was done in United Kingdom in February 2019. Done at Whitney Clinic in London. You imagine that it is very recent technology, just started a few days ago. And I hope it will solve many problems and give us better results that we assume. This is the set. As you see, it is very simple model. You have here the panel, and you have to show the temperature and the duration of the time applied. And this is our catheter. There will be a very good chance to see the set, the instrument, the catheter, and try to handle whatever you want. How to apply, how to plug it, how to do the procedures, everything in details. I think you will have a good time to do it manually. This is the catheter. As you see, this is very small catheter. Go through the great softness or the lesser softness vein through a very small 6 or 7 French sheaths. There are 3 points I want to discuss with you. This is the catheter, and this is the thermal application or the thermal transmission of the wave all around. And this is centimeter. You see, this is the tip, and this is the propagation of heat from the tip. Yes, it propagates about just 2 millimeters. No more propagation of the wave. This is very demonstrative. It shows you how you can go through the great softness up to 2 millimeters only from the greater softness vein. Safely. You can reach up to 2 millimeters from the great softness vein, and you don't have the fear of developing deep vein thrombosis. This is very important. You have the advantage. You can go all through up to the femoral vein, induce your ablation with very short stem. This means the chance for recurrence will be very little with this is little or very tiny, small stem.
But the overlap every 3 centimeters or more, or 1 centimeter?
Yes. This is another point. The time of the procedure. The time of procedure, it will be a little bit longer than you expect for the radio frequency. The pull away speed for the RF is about 7 centimeters. Here, only 1.5 centimeters. You go by 1 centimeter to overlap the whole segment. Let's assume that we are going to ablate the long or the great softness, which stands for about 40 5 centimeter, and 1 centimeter will take about 6 seconds. The whole procedure will be done in about less than 5 minutes. Okay? Every 10 centimeter will take just 1 minute. Then you can ablate the whole great surface in less than 5 minutes. It's not a long duration. You can end your procedure without, let us say, the whole procedure from the time of the patient go to the theater and to go out of the clinic. It takes, let's say, about one hour. In general, why we use endovenous laser? I think your presence here means that you all convinced about endovenous. Endovenous lasers for the doctor and for the patient is very beneficial. For the doctor, it saves time, complications, recurrence. For the patient, it gives him a more chance to go very quick to his job, pain-free procedures, and of course, time, money. Saves money. Now, this is not a costly procedure, and it will save a lot. Hospitalization, general surgery, and so and takes a lot of money. Cost effectiveness of the endovenous lasers is very crucial nowadays. This is the RF. I think we all know what RF stands for, and if we compare anything for endovenous ablation, we compare versus RF, because RF, the first endovenous ablation procedure described, the monopolar radio frequency, and let's say when we compare everything, we compare to RF. In comparison to RF, this technique is much better, easier, less complications, safer, manipulation of the catheter, all of this in favor of the microwave. How does it work? Microwave works for water content. That's why it takes a little energy. When we are discussing laser acts on the blood. That's why it takes a more energy. Radio frequency also acts on water in tissue. Regarding laser and RF, the catheter must be in direct contact with the vein wall to induce its effect. While that's why we compress a little in the case of RF to make it in a very close contact with the wall. In the microwave, there is no need to keep it in direct contact with the wall. It acts on water within the cells, so it denaturates the venous endothelium without direct contact. That means we can ablate a very large vein up to 2.5 centimeters. Imagine if we have a vein of the diameter of 2.5 centimeters, we can ablate it with this new technology. When we discuss laser, we first, long time ago, we were talking about up to 1 centimeter we can ablate. In the RF, we can use up to 1.4 centimeter. Now we are talking about 2.5 centimeters. This is a very huge dilated vein, could be used safely with the new technology. This is the procedure. how to make the procedure. First of all, we let the patient come in the theater and ask him about his position. What do you think, how we can put the patient? Head up or down? Head down. Why?
Reduce size.
Yes. Head down to shrink the vein a little bit and try to empty the vein. This is the first procedure. Please ask your patient to make head down. Some of our yes, this is the point. If you try to put the patient from the start in this head down position, it will be very hard to puncture your vein. Because the vein, it will collapse and it will be very difficult to trace your vein, especially in the transverse position. You can trace it a little bit easier in the longitudinal position. Okay, please put the patient in head up position or leg down position. Cannulate your vein, then ask the patient to reverse his, no, you will tell the patient, now I'm going to reverse your position to empty the vein and make the procedure more easier. Always do the procedure under tumescent anesthesia. Okay? Very, 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 very important. In all cases of endovenous laser, it is very important and it is better to do it under local tumescent anesthesia for many reasons. First, it is easier. Money, less complications. And as we discussed yesterday, if you were with us, does the heat produce nerve injury? Okay. If we do it under tumescent anesthesia, the patient will complain of tingling, not pain. It will, if it induce this neural damage, the early sign or the early symptom, he will complain of tingling. That's why you can change the position, go up a little bit, use your double C. Is there a correlation of the nearby venous nervous element? This is another important thing in using the local anesthesia. Then after you reach the puncture and put your sheath, you apply your catheter, go all the way up to the saphenofemoral junction. Just very few little millimeters, you are in the same position. After you put your needle, insert the sheath, apply the catheter, reach your position, fire. Withdraw 1 centimeter in about 46 degree temperature with a withdrawal rate of 6 seconds per centimeter. This is the protocol of veins up to 1.5 centimeter. If you have vein larger, you can increase the temperature a little bit more, up to 55 degree, and the rate of withdrawal to 7 seconds per centimeter. Again, this is the difference between laser and RF. And this is the pain score. This is very important. If our patient lie in the level of orange, that means he is in about score of 8, immediately, post-operatively, he will drop to the green after the application. From orange to green in few seconds. Okay. Now, let us see what did Mark Whitley talk about the procedure.
And off the veins grew back again. We moved over to pinhole surgery where we passed radiofrequency catheters into the veins under ultrasound control. We then moved on to laser. Now we've moved on to a thing called microwave. The reason we use microwave is because it heats a vein in a very gentle way, and it seems to cause less carbon and therefore less pain. Endovenous microwave ablation is fast taking over from laser in many aspects, and it's something that at the Whiteley Clinic we are now offering. In fact, at the moment, we're the only place in England that actually has endovenous microwave ablation. If you go onto our website, you'll find out more about this innovative new technique for varicose vein treatments.
This was a very quick procedure and a very quick talk from Mark. Now we have the chance to see the instrument, the set, the catheter, and I will leave the mic for Dr. Mahmoud Bakr to tell us more about the instrument, the catheter, and we will all have the chance to make hands-on training with the set. Please, Dr. Mahmoud.
Thanks, Dr. Ayman, for giving me the chance to be with you today. Today, inshallah, we will talk about our device, ECO. It is mainly work by the technology of microwave, okay?
ماشي اتفضل هناك ماشي تسلم ماشي روح
As I told you, that ECO device is a microwave technology. It is the most recent technology in the treatment of varicose through thermal ablation. It is considered as safe and more effective and accurate in the treatment rather than the technology of laser and the technology of radio frequency. It can be used through entry of the vein through the sheath of 7 and yes, and this is the catheter. Okay. And using tumescent anesthesia. The device mainly adjusted at the 45 temperature, and it goes through the vein till the end when we need to make thermal ablation, and we will adjust the device for 5 minutes for each 1 centimeter. The device will get me a pump or after 5 minutes at temperature of 45. He will give me alarm to move out 1 centi, and when the device will repeat again every step, okay, till we finish.
So it took longer time.
No.
Okay, centimeter 2 cycle يعني 2 cycle microwave huh?
Yes. It depends according to the length of the vein or.
That's up there.
I'm speaking about. Yes.
Look, it takes for each centi. 5 seconds, not 5 minutes.
5 minutes.
No, 5
The whole
seconds.
procedure
it will take about 5.
لا هو قال سمعتها برضه كده.
It is 5 seconds for each centimeter.
Still living.
ايمن تيوميسنت على مكان البنكشر بس ولا اللي هو اللينس؟ ليه اذا كان الثيرمال افكت بتاعها
but still thermal.
even 2 مللي اراوند الكاستر افكت السكين؟
No, it will affect the deep tissue. Thermal, if you imagine if you put.
حضرتك قلت الكاليبر بتاع الفين كبير enough يعني.
But still.
ثيرمال.
The difference between thermal and non-thermal.
هو زي ما احنا قلنا قبل كده يا جماعه، احنا قدامنا هنا في 2 ديجيتال رايتين ديجيتال زي ما انتم شايفين. واحده منهم temperature، واحنا قلنا لو هنشتغل على الفين up to 1.5 سنتيمتر we can apply the thermal energy up to 46 below 50. The temperature needed below 30 degrees centigrade, and the time of 1 centimeter withdrawal about 5 to 6 seconds. This is the protocol for up to 1.5 centimeter. If you have a vein greater up to 2.5 centimeter, we increase energy and prolong the time of withdrawal up to 55 for temperature and withdrawal up to 7 seconds.
Okay. This measurement of diameter before interference
Yes.
with the duplex scan in the erector position or during the supine position when you starting your procedure, because the diameter will be different.
Yes.
Okay.
This is a very important question, and it is 2 questions.
Yes.
The question, how can I measure the vein? Then, of course, we have here Professor Khaled Al-Kaffas. He will explain this more better than me. We measure in the erector position, but the question, do we have the great saphenous all the same? No. We'll ask our professor to make the diagram measuring this segment from here to here is about 1.5 centimeter. We have here in this segment, it is about 2.4. This is aneurysmal dilatation of the vein in this region. We apply in this region different protocol.
Different degree of thermal.
Yes, that's why mapping before surgery is mandatory. Mapping during the procedure is mandatory. When you do, before you fire the limb, you draw a map on the skin of the patient. Here, this is lying within 1.5. This segment more than 1.5. Then we reach another segment below 1. Okay? We have to mark the vein very correctly. And you have one of 2 choices. Either you ask a professional radiographer to join you. This is the easiest way. Or, excuse me, sir, you have to master ultrasound duplex if you are going to do it yourself. If you want to do it yourself, you have to a very good sonographer to detect the vein, measure the diameters, be sure we are going to stop from the deep veins. Otherwise, recurrence is inevitable. Either you master duplex or ask a professional to join you. As you see the catheter, القسطرة فينا يا شباب. This is another question. As you see the catheter, very malleable. This is another point differentiated from MRCS. So you can apply it
very easy with the tortuous vein.
tortuous vein. I think the next technology, yes, it will be a slower profile and it manipulates or give the chance to go through wire, on wire. This technology does not go on wire. It is just pull it through the sheath. If we are
The French with the cheese is how much?
7 French. If we can reach a new version of catheter to go through wire, we can do it through 4 French. I think that it will be a very more smart. And I think the company, Mara company, in its way to produce a more smart catheter.
Because there will be a problem with the 7 French cheese.
A little bit.
The most available is the 7 will be limiting effective. So you must think about this. You must be
A
available.
little, but still available. We have in the same technology, we don't have only the catheter, we have needle. As you see the brochure with you, there is a small needle.
In the front of the brochure.
This small needle can through very tiny veins, very superficial small veins.
As you see, this is the needle or antenna, and this is the caster.
So it's for the exo.
I don't consider exo, it is still endo, but in a very small veins.
So can
that-
we use it for perforator?
Why not? You can ablate whatever you want. Yes, yes.
Direct to the
You can go direct to the perforator, go for superficial vein.
So you can do thermal ablation for perforator.
Yes, you
without
can.
need to the cannula or sheath or something.
Yes, you can end up the procedure, the whole procedure, with microwave. No need for another injection or sclerotherapy, or no need to go for another procedure for perforator. You can do it all the same in microwave manner. And let us say that you can vanish varicosity in just below 1 hour.
And the needle included in the package or it is a separate package?
Let's start, and we will satisfy what you want. Okay.
Must be included.
هو
And the patient.
And
حضرتك
the sheath 7 must be available with him.
it is available, okay. Already it is available with sheath 7, and regarding the caster and the device is it is a package all in all. But before I finish, I'd like to confirm that the benefit of ECO new innovative microwave technology, it is better than laser, that it doesn't make thermal burning or ecchymosis or this markers that occur after operation of laser, as it is more severe, and before about us we are more gentle, safe, and have the same efficacy or efficiency as laser in thermoablation. No recanalization occur after surgery, that is most common occur.
Speech. All is a thermal ablation.
Yes.
And according to the experience and according to, as Professor Ayman said, that is you need with you a professional sonorist with you to be sure that is you ablate all the segment. Okay, so to be sure there is this instance of recanalization. But you don't compare now the microwave with the radio frequency until you have the study.
Yes, yes.
Because you cannot be sure about
Okay. We have studies made by the company, and we can send it to you shortly.
Ongoing, it's ongoing.
النيل نفسها بكونكت بالانتنه واعمل سيرفر منها.
Connected, special connector. So this needle is for telangiectasia spiders, or I think so. Spider varicosis or more larger?
no,
More large.
More larger. So you ablate the vein or only the nidus of the vein. So how you can navigate the needle inside the very small tortuous vein? I think it's for spider vein like telangiectasia, like a reticular verrucosis? I think so.
don't think so. I think this is more small, straight thing.
It's not. It's a rigid needle.
No, it is very straight vein, small vein, straight small vein.
But speaking about most of the associated localized punctures is torsions. So
You can't.
You only abate the vein from outside. Segment by segment or
No, it is inside the vein.
the small cluster of radio
Yeah.
frequency
Segmented,
is
yes.
segmented, so it can move with the torsion.
Segmented.
No, it can't move with the torsion. It is can't move with the torsion vein. It is straight.
you have a needle now or not available?
No, not available now.
يعني النيدل التيب هو الانديوس هيتنج ولا اللينس؟
Yes.
التيب اوف
The same as the.
As a catheter.
It has a protective,
التيب
protective sheath around it.
Needle.
The needle can burn the skin.
No. You do also.
To miss it.
This is question about so this is
The same.
the ablation must be in the tip because if all in the needle, definitely it will do some damage to the skin.
But now
if
it
it
punctures
is-
into the skin.
If it is in the sheath, it will not burn. It will not burn. It will burn in the sheath. But the isolating layer will be the tumescent.
This is question. This is most of the needle it is
يعني هو اللينس اللي هيبقى جوه الفين اللي انا هقدر اعمل فيه سيرمال ابليشن بالنيدل ده ايه؟
Whatever, even all through the needle.
ده هيبقى السكين كده.
the tip of
Tumescent. Tumescent, it will isolate it from the pain.
فور ذا سكين يعني جاست انا النيدل كلها انديوس هيتنج.
No, no. It will be transmitted through the metal. That will.
and speaking the coming only from the tip, not from the organs.
Yes, the question that he transmitted through the tip, but he think that it's a metal device, so that it will be transmitted through this metal device. That's aspect.
The precautions takes through the laser. You ablate space just through the knee.
Yes. The question.
Just through the knee to protect softness. To protect softness. What about the microwave?
طالما فيها تيوميسنت يبقى ما ينفعش تحت النيدل.
This is a good question, and I think we answered this question when we are talking about.
Another is also closing.
No, when you are talking about the importance of tumescent anesthesia. Yes, you can, in case of short softness, small softness, it is in a very close relation with the sural nerve. But we ablate the small softness, although it is in relation with the sural nerve. How we can protect? We can protect by two mechanisms. First, using the tumescent to isolate the vein separately.
More tumors.
You do tumescent to isolate the vein from all structures, and you can use your ultrasound to see if the vein is still in relation with nerves. And again, we do it under local anesthesia. If the patient complains of tingling, you have to stop and revise your position. The same procedure we can apply, and you can fire the whole great softness below the knee.
Another point, Dr. Ayman, as you said before, each segment has separate protection or separate measurement for the energy for thermal ablation, like the laser. So if you go below the knee, you must decrease the power of the laser for the segment because the diameter will be different. So with this protection, we can now ablate the low softness below the knee, okay, with very minimal or absent of the nerve edge. If you did good tumescent and decrease the power according to the size of the vein, because there's difference between you ablate 1.5 centimeter diameter and the blue knee is speaking about 6 millimeter. So it must be different. So you don't leave the machine heat everything. So go at this point, step close and evaluate again and do smooth for this segment so you can ablate without harmful effect to the nerve.
I wanted to hear comments of two pioneers in endovenous ablation. I want to hear Dr. Muhammad Awal Farouk.
I'm just my question, you put the technology microwave technology on a flexible caster, but when you went at a smaller diameter, you put it on a straight shaft. And we know that all varicose veins by definition are tortuous, so you wouldn't find any vein which is straight as needed. So my question, why the technology for a smaller vein was not put into a caster, like a flexible caster like we use with laser? The laser, you have the big endovenous laser caster and you have the microfiber. Microfiber are easy, flexible, goes through the vein. And if you have the 2 millimeter of burning limit, this will limit your application for telangiectasia. So why you are going for the market of very small vein, why you have two big defects? The needle is straight and stiff, and you have 2 millimeter. Most of our veins are within 2 millimeter from the skin, so you will burn the skin anyway. And I think the needle, only the tip is charged with microwave. I think it has to do with the microwave cable that is able to transmit. If you get a smaller, you can't do it flexible. You have to do it with a straight shaft. And this is maybe the engineer which have requested to have this platform. So I think this is a good technology to be used in a big great saphenous vein, but to compete for the telangiectasia with this needle device, I think is difficult. It's my comment.
I have answered for one of the questions. Yes, when you are talking, telangiectasia is about 2 millimeter from the skin. After application of the tumescent, we can make this distance 5-6 millimeters, that you can use it safely without the fear of burn. But the other question is totally right. Now, Dr. Khalid.
Sorry, I was late. I didn't hear the production of this machine. I have a question. So, what the privilege of this machine on RFA, radio frequency ablation, or laser? Only the burning. Only.
No, less recurrence. Less recurrence.
But they have no thermal studies. It's a very new machine. I think it's not real. There is no recurrence. We have it's a very
no recurrence. No, the paper that Mark Whitley have made to get CE approval, it put the advantage of lower recurrence rate compared to laser and better tolerance compared to pain. This is his paper. He made 2 groups.
Yes.
You wouldn't get any.
But they have no long-term results.
No,
not yet.
It's only a primary outcome. Primary outcome, the occlusion.
It mentioned in clinicals that recanalization rate was statistically higher in laser. This is why they got CE approval. If you don't have an advantage, we wouldn't give you a license.
Yes, because microwave technology is well known in other areas of radiology, in liver ablation. It overcomes the radio frequency in liver. It's new to us in varicose vein, but varicose vein is not much different than this area with the liver and ablation, because they in the liver they need
more high temperature
and localization. Yes. So what's the privilege of this machine or other?
If you go through the paper, the primary point and recanalization is less in microwave. This is number one, as it works on the water within the cell, so the denaturation of the endothelium is more and the chance for recanalization is less. This is number one. This is another hypothesis that in lasers, the recommended distance from the saphenofemoral junction is about 15 to 20 millimeters. This gives you a very long stump.
Yeah.
This will invite recurrence.
Yes.
This long stump will be abolished in microwave.
Okay.
This is another cause of making it better in terms of recurrence. And the temperature used here is about 40 millimeter.
Which is a very small comment. I think even if you have such accuracy of 2 millimeter, I wouldn't do ablation until 2 millimeter from saphenofemoral junction.
Why not?
Now the area Dr. Ayman is well known about this. Thermal prostatectomy now is worldwide done now.
And we know it is safe if you leave 1.5 centimeter
No,
from
no,
saphenofemoral junction.
no. Zero. Zero.
Ground level.
I wouldn't do it.
But this is a problem with the illustration today about one of the main anomalies at this area with the anterior axis.
Yes.
Which is
So
much and responsible for
But the surgical mind of closing collateral at saphenofemoral junction have changed with the endo-ablation.
Yes.
Now you can leave 1.5 centimeter, and we know by registry trial of 5 years follow-up, it doesn't make a difference.
No,
We know that we all-
some recent papers, it says
Recurrence,
it's not the stump have a more chance for recurrence.
So correct me if I'm wrong. I think to summarize this is a machine that's less aggressive than laser, but more flexible than RFA.
Yes.
Yes. This is only the privilege. Yes. It's a flexible
And cheaper.
and cheaper. So let me ask, the origin of manufacture is Chinese or what?
It is a German technology.
Chinese is not
Yes,
not
but
bad. Don't worry about the Chinese.
Yes,
I love Chinese. It's not
It is a German technology, and it is made in
Chinese is good.
China.
I like Chinese food.
But I'd like to confirm, as you said, Doctor, that we have also a satisfying result than laser, and after
So I think it's more flexible than RFA and less aggressive and more safer than laser.
and it gives the same effect.
But you lack the long-term results of recurrence. Yes.
Yes, and I think it is a good benefit for echo, and I think this will have welcome from you, and can have a chance with you, inshallah.
Okay. What about the total cost of 1 piece? The most important question, the most final and important question.
For customer and the device to make a case, it is 7,000.
No, the machine and all the bargain if you want to.
all
buy
is
it.
7,000.
No,
It's not Chinese. دي بص دي بالعادة
If you buy
They're free.
if you buy the set, you will get that for free.
So how many customers?
I don't know.
Only negotiation with the company, man.
Thank you all.
Thank you.
I appreciate your presence for coming early and spend the morning with us. Please, I ask you to join the conference, and we can discuss all the procedure with the company, every details regarding money and so. Thank you. Have a good day.